In terms of resistance, we always think about two types of resistance, so-called primary resistance, where the tumor cells are resistant to your treatment, and secondary resistance, where they are sensitive initially but then develop resistance. But I think what we are finding now is that the whole idea of tumor cell heterogeneity, which is over time, when you have a massive tumor, there are different types of cells in them. So for the first time, we've been able to prove that in the same tumor, you might have different mutations. So when we use these new targeted therapies that are hitting a specific type of mutations, we are finding that in some cases, these drugs do their job. They kill off all the cells with that mutation. But in that population of cells, you had other mutations that these drugs don't hit. So over time, those other cells grow back. Okay. So in lung cancer, where EGFR inhibitors have worked for a long time, there was a mutation that we call the resistance mutation. And the initial thought was that you treat with, let's say, a Tarceva, and the cells develop this additional mutation. And for the first time, we are finding that if you use sensitive techniques to genotype the cells, you see these resistance mutations coexisting with the sensitive mutations at the time of diagnosis. So you kill off these, and these other ones grow back. But back to immunotherapy, again, the idea is that if you have a drug that is targeting the interstitium of the tumor, because you don't have this kind of genetic variations, you might be able to inhibit the tumor for a much longer time. Okay. So at least theoretically, the feeling is that some of these immunotherapy approaches might be better. But having said that, the system is very complex, because with angiogenesis inhibitors, for instance, we are finding that sometimes over time, the tumor secretes other factors that will still stimulate blood growth. And so it's a very complicated situation. The other thing we are seeing that we are beginning to try to address is what we are calling a rebound phenomenon, in the sense that you have the tumor, you treat with the drug, it shrinks the tumor nicely, and then it looks like the tumor starts growing. And so, as we did with old chemotherapy, when something like that happens, you stop the drug. And what we are finding is that if you stop the drug, the tumor starts growing like crazy. So in a sense, even though the tumor has started growing, these drugs were slowing it down, And so if you remove the drugs, it's like removing the brakes, and the tumor starts growing like crazy. So there are new concepts that we're trying to delve into, deal with, which is that it may be that we have to start looking at situations where if you have one drug and the tumor seems to be growing slowly, instead of stopping it, you should keep it, but rather add something else. Okay. The other idea also is that we have to start thinking about combining these drugs rather than using a single drug, because really a lot of the difficult to treat diseases in medicine where we've made progress, we've done that because we combine drugs rather than using a single drug. Good example is HIV, where you use a cocktail and we're able to control the drug for a long time. Another example is tuberculosis, which is a bacteria that has been very difficult to treat. And the successes have been when you do combination therapy for a long time. Whereas if you use one type of therapy, these are not cancer cells, these are infectious agents, but they become resistant very quickly. And so I think we have to start thinking about approaches like that in terms of overcoming resistance.